Our next speaker today is Carmel O'Keefe. Carmel is an oncology clinical nurse specialist, and she works in the Oncology Day unit in St. Luke's Hospital in Kilkenny. She qualified from Cork University Hospital in 1994 and has been working as a clinical nurse specialist in St. Luke's Kilkenny Oncology since 1999, leading a nurse-led Oncology Day ward and overseeing its evolution from a single nurse service to a busy 10-bed day service with 6 members of the nursing team. She's involved in ongoing professional development and including qualifications in advanced breast care, oncology, healthcare management and X-ray prescribing, as well as being an active member of the INMO locally and nationally. And she's going to give us a presentation, the different types of cancer and treatments and just the assessment of symptoms. So thanks for that, Carmel.
Hello, everybody, and I'd like to take this opportunity to thank the INMO and the Telephone Triage group for
Carmel, if you could just unmute yourself, please.
Carmel, it should be the button on the bottom left of your Zoom.
Sorry now, there. Can you hear me now?
That's perfect. Thanks, Carmel.
Okay, no problem. Now, everybody, thanks for inviting me along today. It's an honor to speak here, and I've really enjoyed the talk so far. I work in the area of oncology and have done for a long time now, and I really enjoy my job, and it's brought new challenges every year, and the world of oncology has been changing hugely through the era. So about 45,000 people in Ireland are diagnosed each year with a cancer. The incidence is growing, but more and more people are surviving than ever before. Every 3 minutes in Ireland, somebody gets a cancer diagnosis, and every hour somebody dies from cancer. So 1 in 4 deaths in Ireland are related to a cancer. The most common cancers we see are skin cancers, about 13,500 a year, growing due to lifestyle and sun exposure. Prostate cancer, breast cancer is about 3,500 of each per year. Bowel and lung cancer, about 2,500 a year. In Ireland, about 1 in 2 people have a lifetime risk of cancer. And this is predicted to see a doubling by 2045. So unfortunately, everybody in their family has some exposure to the world of oncology. The topics I'm going to visit today are types of systemic anti-cancer treatment. We've tended to move away from the word chemotherapy solely at the moment because there is a whole new range and plethora of drugs out there, and chemotherapy is only one form of treatment. The advances in systemic anti-cancer treatments, immunotherapy, and also the new National Cancer Control Programme tool for telephone triage, which may interest the group here. Types of cancer treatment are wide and varied. So when a person gets a cancer diagnosis, it should be brought to a multidisciplinary team meeting in order to see what way we travel with the program. Do we go surgery, radiation therapy, chemotherapy, immunotherapy, hormone therapy, targeted therapy, and stem cell therapy? Some people may have treatment with chemotherapy prior to having surgery to downstage the tumor. Chemotherapy, unfortunately, is still the mainstay of treatment. It is a medicine used to treat cancer. Chemotherapy kills cancer cells, and it may be used to cure cancer, but it can help keep it from spreading or reduce symptoms. In some cases, people are treated with a single type of chemotherapy, but often people get more than one type of chemotherapy at a time. This helps attack the cancer in different ways. Treatment can be aimed at cure, prevention and reoccurrence, reduction in tumour size to allow surgery at a future date, or for palliation. Chemotherapy can be delivered in lots of different ways. Intravenous chemotherapy, and you may notice some of the patients coming across your path. It may have oral chemotherapy. They may have intravenous lines like a PIC or a port. PIC lines are usually peripherally inserted cannulas. Portacast tends to sit under the skin. It's a central line. Then it is the chemotherapy could be injected in some places, and chemotherapy can be given into the peritoneum or abdomen. Topical chemotherapy is sometimes used on skin cancers. So oral chemotherapy or chemotherapy tablets, most people are motivated to having a tablet treatment. They think this is easy, I can take it at home, it's just another pill. But it's not available for all treatments. It's also a very specific group of patients who can have this kind of treatment. It causes more interactions with any other medications they may be on. There is restrictions around using chemotherapy with some of the PPI agents, and also compliance can be an issue. So it's a very specific group of people that it's used for. Chemotherapy into the peritoneum or abdomen, it's not widely available. It's the one that we tend to have in Ireland is used in the Mater Hospital. It's called HIPEC. It's a cytoreductive surgery with heated intraperitoneal chemotherapy. It's used for very certain cancers, such as appendix tumors, advanced colorectal cancers, rare intra-abdominal tumors. It's not something you see very often. It's highly toxic, and unfortunately there's a very high mortality rate with this. Next slide, please. The drug, dose and treatment schedule depend on many factors. These include the type of cancer. This must be always biopsy proven. So many doctors, they see a cancer on a scan or what is presumed to be a cancer. We always need some tissue. It's not even nowadays with the amount of newer drugs that are available, we need to know whether it has any overexpression of genes, if it's got specific proteins on the surface of the cell. So that allows to open to newer modalities of treatment. The tumor size and its location, whether it's spread. We call this staging of cancer. So it's staged from 1 to 4, being localized, small, encapsulated, spread to local lymph nodes, spread to distant organs, and that's unfortunately usually a stage 4, and typically it's not a curable situation. Your treatment then may vary on your age and your general health, what comorbidities you have, your body weight, how well you can cope with side effects. Again, what are you bringing to the table? Have you got diabetes? Have you got obesity, COPD, any other medical conditions? And have you been previously treated for another cancer or a previous cancer in the past? Your tolerance to treatment will be affected. In some cases now, we have newer testing available to see if somebody even needs chemotherapy. In the likes of breast cancer, we have access to Oncotype DX genomic testing for people diagnosed with an early stage breast cancer that is hormone sensitive and has an overexpression of a thing called HER2 on the surface. So when they go to MDT, they look at the tumor and they decide, yes, this is one that's suitable. So they send away a sample of the tumor to see if it's got a reoccurrence risk score. This can take an extra 2 weeks and a very anxious time for the ladies while they're waiting. They just want to get going with treatment. If it comes back though, as a low reoccurrence risk, it's good news for them. So it comes 0 to 100, and in a lady over 50 years of age, a reoccurrence risk score of 0 to 25 means there's an unlikely benefit of chemotherapy, and they'll get away with just hormonal treatment. In ladies less than 50, 0 to 15 means no treatment is beneficial and hormone treatment only. And 16 to 20 means a very low risk also, but some people will choose to have chemotherapy in consultation with their oncologist. This is usually a very fraught time for these ladies. Sometimes it's easier to just hand them the treatment. They expect treatment, but putting them at a lifetime risk of all the chemotherapy complications, it's a great saving for them and their bodies if they can get away without it. Next slide, please. Side effects of chemotherapy. This isn't an exhaustive list by any means, but it's just got some of the most common side effects. Everything from brain fog or chemo brain, it's a very realistic side effect. And people can't think, they can't concentrate, they forget things, very hard to maintain a work schedule, multitasking. Anxiety and depression, hot flushes and menopause, infertility in younger women, cardiotoxicity, nausea and vomiting, the one we all hear about. Thank God nowadays it's much better controlled with the newer agents we have. Discolored and cracked nails, loss of appetite, sexual dysfunction, skin sensitivity and sometimes neurotoxicity. Hair loss, something we hear about all the time. Over half of our drugs cause hair loss. In some centres, they may have access to scalp cooling, which may minimize hair loss. Mouth sores, lower blood count, which can pick up infection and need transfusions. Digestive distress, urination issues and coloured urine. Bone density loss, poor coordination and muscle wasting, and swollen hands and feet. So how do we measure these? We measure them every time the patient comes into the unit. We have any contact with them, they ring, they have a problem, we assess them systemically. So we start asking questions and we go through each system. And we use the NCI, which is the National Cancer Institute's common terminology criteria. This latest version 5 came out in 2017, and it grades side effects from 0 to 5. So 0 is none. Grade 1 is mild and asymptomatic and there's no intervention required. Grade 2 is moderate, minimal non-invasive intervention is required. This usually impacts people's instrumental activities of daily living. Grade 3 is severe or medically significant, but not immediately life-threatening. Hospitalization will probably be required, and it's disabling and it's interfering with self-care ADLs. Grade 4 is life-threatening and urgent intervention, and grade 5 is death. So obviously we want our patients to ring when it is a grade 1, so we can offer advice to them over the phone. So say if it's diarrhea, to start their Imodium, what the program is, to ring back the following day to prevent them ever getting to a grade 2 or a grade 3. And ongoing education happens in the oncology unit, and each time they come in, some people are poorer to report than others, and they're afraid of coming into hospital. But unfortunately, if it's a grade 3 side effect, they need to come into hospital. This is something you may come across in telephone triage, where patients have a side effect related to treatment, and if they can't get through to their own oncology unit, they may contact the telephone triage service. So it's important to talk them through. They're usually very anxious, very distressed, don't want to come into hospital. But really, if they've got a grade 3 diarrhea and not resolving with Imodium, and they're getting dehydrated and feeling low blood pressure, there is only one pathway into hospital at that stage. Next slide, please. Another route of treatment is hormone therapy. It's a cancer treatment which slows or stops the growth of cancer that uses hormones to grow, such as prostate or certain breast cancers. This can also be called endocrine treatment. Endocrine treatment tend to work in either of two ways. They can block the body from producing hormones, or they can interfere with how the hormones behave in the body. Hormone therapy can be used alone or in combination with other systemic anti-cancer treatments. Next slide, please. In men, we use hormone treatment for prostate cancer, and it's got unfortunate side effects. Hot flushes, not confined just to women, they can happen to men too. Loss of interest or the ability to have sex. This can lead to issues with compliance with treatment, weakened bones and osteoporosis. So many of these patients will need to be put on calcium supplements. Diarrhea, nausea, enlarged and tender breasts, and fatigue. In women, we use hormone therapy in certain types of breast cancer. And they bring unfortunate side effects too: hot flushes, vaginal dryness, changes in your periods if you've not reached the menopause, loss of interest in sex, nausea, mood changes, and fatigue. So it's very easy to hand somebody a prescription, say for a breast cancer patient, for tamoxifen for 5 years, and off they go. But if they're having side effects and you haven't opened up the conversation of how to deal with them, they may not comply. They get some of these issues and they go, I can't talk about that. It's opening the channels of conversation so that they know they can talk to you, that they know they can ring if they have an issue, and they can come back to clinic, have a discussion, either virtually or face-to-face, and discuss the issues and see if there's any alternative treatments or some way of treating the problems. Unfortunately for women, most of these are hormone related, so the obvious choice would be to put them on HRT, but HRT will counteract the effects of the tamoxifen. So that is not a therapy we can advocate. If it is used for very severe symptoms, it is used for very short bursts and stopped again. Next slide, please. Another modality of treatment is radiation therapy. In Ireland, we have centres in Dublin, Cork, Galway, Limerick and Waterford for the public. It's a type of cancer treatment that uses beams of intense energy to kill cancer cells. Radiation therapy most often uses X-rays, but protons or other types of energy can also be used. The term radiation therapy most often refers to external beam radiation therapy. Next slide, please. The effects of radiation are local, so they tend to be transient. They tend to be during the radiotherapy and for a short while after, but some can be lifelong. So they can get skin toxicity to the area that's being irradiated, and their radiotherapy nurse will give them skincare advice. So if they ring an out-of-hours service like yourselves, they will have been given skincare advice, and they usually recommend not to use emollients during the radiotherapy period because this can exacerbate the radiotherapy beams. So they will have been given advice. Tiredness, hair loss. Hair loss is only applicable if the skull vault or the brain is being irradiated, and this may be not reversible for them, so it's very distressing. Nausea and anorexia, particularly if the beams are on the GI tract. Stomatitis for head and neck cancers, difficulty swallowing in esophageal cancers. Diarrhea if the pelvic area has been irradiated. Stiffness of the joints or muscles. Sex and fertility issues may be long-term if the pelvic area has been irradiated. Emotional effects, lymphedema and breast cancers, and secondary cancers. Secondary cancers are seen mainly where high-dose radiation is used in childhood cancers, and they may present with a secondary cancer later in life. Next slide. So some of the newer therapies we're looking at now: targeted therapy. This is a type of treatment that uses drugs or other substances to identify and attack specific types of cancer cells with less harm to normal cells. Some targeted therapies block the action of certain enzymes, proteins, or other molecules involved in the growth and spread of cancer cells. So as I said earlier, we now need not just the cell biology, is it in in lung cancer, is it small cell or non-small cell? We also need to see the overexpression of the genes. Is it ALK mutated? Is it PDL positive? And this opens up so many other treatments to us. Targeted therapies differ from standard chemotherapies in some ways. Targeted therapies act on a specific molecular target that are associated with the cancer, whereas most standard chemotherapies act on all rapidly dividing normal and cancerous cells, so they tend to have a more systemic side effects. Targeted therapies are deliberately chosen or designed to interact with their target, whereas many standard chemotherapies were identified because they kill cells. Targeted therapies are often cytostatic, that is, they block tumor cell proliferation, whereas standard chemotherapy agents are cytotoxic, that is, they kill tumor cells. Next slide. So many different targeted therapies have been approved for use in cancer treatment. These therapies include hormone therapies, signal transduction inhibitors, gene expression modulators, apoptosis inducers, angiogenesis inhibitors, immunotherapies, and toxin delivery modules. An example of this would be one of the treatments I spoke about earlier, which is the HER2. HER2 inhibitor targeted therapy works against HER2 positive breast cancers, and it acts by blocking the ability of the cancer cells to receive chemical signals that tell cancer to grow. This applies to about 1 in 5 breast cancer. It would be given usually alongside other treatments such as hormone therapy or chemotherapy, and it's got quite a long delivery period. It goes on for 12 months from the time of start of therapy, but very well tolerated. So it's given us these breast cancers tended to relapse very quickly, but since the advent of this has allowed us another way of hitting the cancer cell and preventing reoccurrences. Next slide. Immunotherapy. This is the new exciting area in cancer treatment. You read about it on the papers all the time. And in the current environment, our patients are very well informed. First thing they do, or their family members do, is when they're diagnosed with a cancer, they go to Dr. Google. And that they don't want the boring old chemotherapy, they want the newer drugs. And they're coming and they're asking us about this. So immunotherapy is there. It's there for a lot of cancers. Next slide, please. So immunotherapy is a type of cancer treatment that helps your immune system to fight the cancer. Several types of immunotherapy are used to treat cancer. These include immune checkpoint inhibitors, T-cell transfer therapy, monoclonal antibodies, treatment vaccines, and immune system modulators. Next slide. So they have lots of side effects. They don't tend to cause as much issues as chemotherapy-related side effects, but they are very varied, very different to what you may have come across in your time dealing with chemotherapy patients or cancer patients in the past. So we say to the patients, it can cause anything but rhinitis, causes inflammation. So we ask them to carry an identity card, and if they present at their GP or the ED department, that they show them they're on the immunotherapy. Immunotherapies tend to be given in mainstay at the moment in the palliative care setting. They're extremely well tolerated, and they may be on it lifelong or until disease progression. So it can cause uveitis. Pneumonitis is a common one, so they may present with a short cough. And in this COVID era, it is important to rule COVID first. We recommend all our patients to get a COVID vaccine. Some of them will choose not to have it, but in the immunocompromised, a COVID vaccine may not have great efficacy. We're not really sure what percentage efficacy it has in this group of patients. So of course we'll have to outrule COVID if there is, particularly if there's a fever. But somebody who's recently after starting immunotherapy and has a short cough and increased shortness of breath, we do need to get a chest x-ray and maybe a CT scan to see if it's pneumonitis. Hepatitis, we do a hepatitis screen on all our patients before they start immunotherapy. And if they've had previous hepatitis exposure, they may need to be treated for hepatitis throughout their immunotherapy to prevent a reactivation of their hepatitis. Pancreatitis, they can develop treatment-related diabetes, and that'll have to be managed. They can develop hypo or hyperthyroidism, and that'll have to be managed, and that's evaluated each time they come in. They can get arthralgia, and this can be quite debilitating. So again, we use the same grading system, the NCI, CTC, and we grade all their side effects from 0 to 5, and we intervene where necessary or give self-care advice. But it's just to be aware, this is something that's out there now, and that these patients could have come across your service. Colitis, when we've heard a lot about endoscopies and bowel issues, and colitis is reported quite commonly in it. We in our practice have not seen as much incidence. Where it comes, it can be quite severe. So we would ask the patient, have you had 5 or more bowel motions past your normal? Is it loose, watery? Is there blood in it? We will assess them as an urgent, and they may need admission to hospital. Some of these patients will require admission for IV methylprednisolone and maybe even infliximab, and may need a prolonged hospital admission. But the incidence of side effects on immunotherapy overall is quite small. Next slide. Can anyone receive immunotherapy? And back to the people coming in with their bit of paper and Dr. Google. Unfortunately, it's not for everybody. Although approved agents and indications for immunotherapy are broadening and others have been explored in a vast number of clinical trials, not everyone can be considered for immunotherapy. Some immunotherapy agents require that certain antigen receptors and targets be present on the surface of tumour cells to be effective. So like that, we look for a good biopsy. We may send patients back for a second biopsy because there isn't enough tissue to give us the data we need to see if they're suitable for these immunotherapies. Researchers continue to identify new targets and assays to test for the presence of these antigens. And as we learn more about how cancer cells are communicating with and evading the immune system. Additionally, some immunotherapy agents result in an immune system being put into overdrive and can result in an overactive immune system. Patients with a history of autoimmune disorders may not be appropriate for all forms of immunotherapy. Careful consideration should be placed on the likely benefits and risks before starting any cancer treatment. And again, as I said, many of these patients are in the palliative setting, so you do have to do a risk-benefit analysis on them and fully informed and consenting the patient. Next slide, please. A little word on telephone triage, considering the group we're dealing with here. And this is the new telephone triage tool, been in operation a couple of years in Ireland. It was adapted from the UK Oncology Nursing Society by the National Cancer Control Programme. It's in use in almost all the oncology settings throughout the country. Next slide. It's a traffic light system, as you'll see there. The common toxicities are on the left, and then it's a green, amber, and red. And we have these hanging at all our telephone sites. We give our patients a mobile phone number to contact us if they have any problems. Unfortunately, our unit doesn't have an inpatient unit, so our availability is only Monday to Friday. And of course, these things tend to happen out of hours, so they may end up coming across your service out of hours. In an ideal world, it would be 24 hours a day. In other centres, it is managed. This can vary from a phone being carried by one of the nurses to an answering machine, which is picked up every hour. It is important to remember when assessing an oncology patient, if they're on immunotherapy, the side effects of immunotherapy can be anything up to 12 months post immunotherapy. Next slide. So the aims of this toolkit: it delivers guidance and support to the practitioner at all stages of the triage and assessment process. It's a simple but reliable assessment process. Safe and understandable advice for the practitioner and the caller, so you know you're giving the right advice, you know you're assessing correctly. High quality communication and record keeping, competency-based training, which was provided through the NCCP. It provides an audit tool and a record on the system. Now, the UConn's toolkit does not give us guidelines on patient management post-admission or admission pathways, but it does support the recommendations and assessment by the practitioner who carries out the triage. Next slide. So it looks a bit like this. We keep these at all the telephone desks. So all green is self-care advice. 1 amber usually means review within 24 hours, either in person or by telephone. 2 or more amber is escalate to a red, and a red is always attend for assessment as soon as possible. So when you're carrying out your assessment and you hit a red, so say they have a fever greater than 38 degrees, you don't need to continue the assessment, you need to get them to present. The triage log sheet is completed with a record of the action taken and a copy placed in the patient notes. The patient's consultant should be informed of the patient's attendance and/or admission. So it's very useful, and we keep a copy then for auditing and looking back at our service and how much contact we've had and whether we managed to avoid hospitalizations in this group of patients. Next slide. So the future, new approaches to tame the immune system in the fight against cancer are getting us closer to a future where more and more cancers are going to become curable. But there are many challenges ahead. Capacity in oncology units as cancer rates increase, as you've heard, and population increases, and patients also survive longer on maintenance treatments. Patients are left on treatment longer. There's a shortage of oncology beds and oncology nurses, as is common in all other areas of nursing. Ongoing education for our staff. So all these new therapies and side effects require that our staff need to keep up to date on what's going on and what's ahead and what the new treatments are. The unpopular thing of the economics of these drugs, the cost of the newer drugs. Can we as a country afford them? A dose of pembrolizumab, which is one of the newer immunotherapy agents, is 9,000 a dose, and that's administered every 3 weeks until progression of disease, which could be many years. So the important thing is that prevention is better than cure. So following the Irish Cancer Society's advice, keeping weight down, eating a healthy diet, exercise, be sun smart. Less than 10% of cancers are genetic. So getting into cancer advice, avoidance and lifestyle. Next slide. Thank you very much for listening, and I'm happy to take any questions.
Hi, Carmel, this is Geraldine here, and thank you so much for that. There's a lot of information there,
Yeah.
a lot of stuff going on. Now, I just have kind of like a very query. You know, when patients, say, post-chemo have fevers,
Yes.
and I suppose really, is it always to advise them to go to hospital, or could you actually say to maybe take paracetamol, or what would... And also on the second part of that question is, say a temperature with, say, 37.5, would they be automatically referred to ED, or what is the temperature
yes,
number?
So on the grading system, it says 37.5. We advise, locally, we advise our patients a temperature of 38. We will always tell our patients once they start on chemotherapy that they should not use antipyretics. So we want to see what their temperature is doing. So we would ask that they don't advise take paracetamol. So if their temperature is up, they need to go to hospital. So they need a white cell count done to see if they're neutropenic. If they're neutropenic, they will require hospitalization and intravenous antibiotics. So it's trying to assess them. So avoiding antipyretics, yes, unfortunately, always a patient on chemotherapy with a fever, we'd ask them to come into hospital.
Grand. And just Carmel, a very, very general question came in there. Why is the incidence of cancer so high in Ireland? Or have you any thoughts on that?
I suppose, yeah, there's lots of talk out there, but it is high all over the world, and it's probably a lot of our lifestyle. So obesity, processed foods, exposure to sun, people going on holidays that they didn't have before, increased smoking. So we're seeing a lot more lung cancer in females because a lot more smoking in female, exposures to chemicals, and also people are living longer. We're doing a great job in other illnesses, so people aren't dying of other illnesses, so they're living old enough to develop cancers.
Great. So that's all I have at the moment, Carmel. And thank you so much for that. All right.
Thank you.